Hey everyone, welcome back. Welcome to another week of RMS 701, Foundations of Rehabilitation and Movement Sciences. We are going to be continuing on this module that looks at history and policy to help prepare us to be leaders in our respective fields. This is a quick turnaround on the rehab component of it because we have a module that's going to take us and build upon our discussion about the importance of history last time, a discussion about where history has led us in terms of our rehabilitation, and our professions, our subspecialties, and our areas of research. And we're going to take a look at how it impacts us potentially today and how history is important to give us an understanding of some of the current topics in healthcare that we need to be aware of as leaders in our profession. Understanding these past history will help us understand how it impacts us as decision makers for the future. So we're going to start by taking a look at those factors that influence us on a domestic level, and we'll carry on in the next week taking a look at how these things influence us from an international perspective or global perspective. So our learning objectives for this week are to be able to analyze the various domestic healthcare models and to be able to analyze the history and analyze the use of a rehabilitation model called the ICF model. So, in order to understand our role and our decision making as leaders in terms of current U.S. policies, we have to have an understanding of the history that underlies some of our healthcare policies. So we're going to be taking a look at the history of U.S. healthcare reform. So take a look at that picture on the right or on the left, because we're going to be going through each of those topics a little bit in the next couple slides. So the first concept of healthcare, at least an established healthcare that spans the nation, really took place in 1865, and it came about as a result of some of the aftermath of the Civil War. After the Civil War, a lot of people got set free, and as they were set free, it soon became a realization that there were healthcare needs, there are economic needs, there's educational needs, there are housing needs for the people that were set free. You couldn't just turn them loose without being able to provide for them as well. So with this realization in 1865, there was a formation or establishment of an act by Congress that would provide for these things for people who would be freed. It actually took place a couple months before the Confederate Army surrendered to the Union. So there was a lot of forethought in terms of how are we going to provide for the people that became free citizens of the United States. So the Freedmen Bureau was established, and before it was known as the Bureau of Refugees, Freedmen, and Abandoned Lands, and it was established by Congress in 1865. So what was the function of this Freedmen's Bureau? Well, it was to help millions of former black slaves and poor whites in the South in the aftermath of the Civil War. The Freedmen's Bureau provided food, housing, and medical aid, and established schools and offered legal assistance to the freedmen. So it was really the birthplace of government programs designed to provide health care for its citizens. So from the start in 1865, there was actually a movement in 1912. In 1912, Teddy Roosevelt was unhappy with the current legislation. At that time, Taft was president, and Teddy Roosevelt had backed Taft as the president of the United States. But he was unhappy with the way Taft was running things. And so he decided to run kind of as a third-party candidate. He ran under a party called the Bull Moose Party. And in 1912, that one of the pivotal platforms that they ran upon was this concept of they didn't call it managed health, but healthcare for the nation. So Teddy Roosevelt ran as a Bull Moose Progressive Party candidate in 1912. And like I said, he had a problem. He was feuding with Taft. So this progressive platform, what they called for was the protection of home life against hazard of sickness, irregular employment, or old age. And he proposed the adoption of a system of social insurance to help people who were in need. So you can see how this set the foundations for potentially a healthcare system in the United States. Fortunately, Teddy Roosevelt lost his bid for presidency, and so his platform and candidacy never turned into public policy. It wasn't until 1946 that the Hill-Burton Act was put in place that we start to see some changes in how the government viewed medical care. Hill-Burton Act was really foundational because what it did, it provided funding for a majority of the healthcare institutions in the United States at that time. So what the Hill-Burton Act did is it provided construction grants and loans to communities in the building of healthcare facilities. A lot of the older facilities that you see these days that were built around the 1950s were a result of this Hill-Burton Act. The idea was to build hospitals where there was need so they could be sustainable and they could provide healthcare services for those people that were underserved. It was so successful that by 1975, Hill-Burton had been responsible for construction of nearly a third of the hospitals in the United States. At that year, in 1975, Hill-Burton was rolled into a bigger legislation package known as the Public Health Service Act. And so together, the Hill-Burton Act and the Public Health Service Act, they together were responsible for the construction of a majority of the facilities, so that by the turn of the century, about 6,800 facilities in about 4,000 communities around the nation had been financed by one of these two laws. And it was expanded not only to include hospitals and clinics, but also rehabilitation centers and long-term care facilities. It was, unfortunately, because of funding deficits and because of budgetary requirements, 1997, the Hill-Burton Act and the Public Health Service Act were mothballed, and they came to an end. And so no longer are public facilities funded by either of these two acts. But you can see how they were responsible for the construction of facilities necessary to support these insurances and this provision of healthcare to the masses. In 1946, there was also the first Mental Health Act, and it was important because it established not only a physical need for people, but also that there was cognitive and psychological needs for people. And so it helped establish funds for the first National Institute of Mental Health. And this National Institute of Mental Health made mental health of the people a federal priority. So not just a private, but also a federal priority. And the reason, one of the moving factors, or one of the things that moved this forward, was the realization that people coming back from war who had served our country were coming back with mental issues as a result of the war. And this was an effort to help provide not only physical care for our returning veterans, but also take care of their mental needs as well. Probably the thing that you're most familiar with as we start to get more contemporary history is this concept of Medicare and Medicaid. Both of these programs are still present today, and they still are major policies that influence not only budgets, but also federal policy these days. So an understanding of the history of Medicare is essential for you as leaders in the future. Realize that Medicare and Medicaid were both established in 1965, but really it had its birthplace, or its first conceptualization in 1945 with President Harry Truman. Truman, as one of his major platforms, he was pushing for the idea of a national health plan to provide health coverage to everybody in the United States. But because of battles with Congress and because of other legislative agenda issues, he was never able to push forward this dream of a national health care plan for the whole nation. It wasn't until 1965 that Lyndon Johnson signed to law a bill that provided for what Truman had first envisioned. And that bill was the inception of Medicare and Medicaid. Medicare and Medicaid started as this basic insurance for all Americans who didn't have health insurance. And it originally included two things, both a Part A, which was the hospital insurance, and it also provided Part B, which was medical insurance. So both this hospital insurance Part A and this medical insurance Part B were part of this original conceptualization of Medicare and Medicaid. It's interesting to note that it was not for older people at that time. It was mainly meant for people who could not afford health insurance. It would be provided for them by the government. It was also interesting that the very first recipient of Medicare and Medicaid was Harry Truman. And so Harry Truman was Medicare recipient number one. So history repeats itself. It was in 1972 that Nixon expanded coverage to those over 65. And so oftentimes we, as the current generation of healthcare people, have a tendency to think of Medicare and Medicaid as the insurance for older people. But realize that it really didn't have its birth as something for older people. It had its birth for people who could not afford insurance. It wasn't until Nixon, 7 years after its original inception, that he expanded to include people over the age of 65. Another important healthcare issue was this concept of COBRA. So one of the issues that was plaguing the nation was that people who became unemployed or people who lost their jobs did not have medical insurance, because once they lost their jobs, a lot of times their jobs were tied to medical insurance. Their medical insurance was tied to the jobs they had. When they lost their jobs or became unemployed, they could no longer provide medical care for their families and for themselves. So what happened is that Congress and legislation put together this Consolidated Omnibus Budget Reconciliation Act that's known as COBRA. And this act gave workers and their families who lost their health benefits the right to choose to continue group health benefits provided by their group health plan for a limited period of time. So kind of like a rescue line or a security blanket for those people who had lost it. It gave them a window in which they can still get insurance and gave them a chance to find other jobs to provide them insurance. The circumstances to be eligible for COBRA at that time and still today would include involuntary job loss and reduction in hours worked, a transition between jobs, death, divorce, or other critical life events. So if anything of these happen and you lost your health insurance, COBRA would allow you to continue your health insurance until you found something better. In the 1990s was the first time Medicare was really revamped, and that revamped Medicare was called Medicare Advantage. In the 1990s, legislation opened Medicare up to additional provider options. So before the 1990s, Medicare was primarily provided by the government. It was federally funded, and the funding for medical care was provided by the government. It wasn't until the 1990s that it opened it up to other providers, and the majority of these providers were the HMOs. So Medicare Part C, or the Medicare Advantage, is really Medicare that allows participants to choose HMO coverage rather than government coverage. Now we dive into a little bit in terms of how rehabilitation is involved in this whole healthcare package. So most of you are familiar with the ICF, and so I'm really not going to talk a whole bunch about it. I realize that most of you got it in your physical therapy, your athletic training, your occupational therapy coursework, but I do want to highlight that how important it was, because it gave us a common language. It gave rehabilitation experts across the globe a language in which we can talk not only from a research perspective, but also from a funding and reimbursement standpoint, and from a legislative perspective. The ICF model took place in 2001. ICF stands for the International Classification of Function, Disability, and Health, and it is the framework for describing and organizing information on function and disability, which is really the things that we deal with as rehabilitation experts. Like I said, it provided a standard language and a conceptual basis for the definition and also the measurement of health and disability. In 2007, it was expanded from an adult model to a children's model. So there was a children's component of the ICF that was developed. And all of these, the important thing to realize that it doesn't occur in isolation. The unique thing about the ICF is it doesn't look at things just purely from a personal medical perspective. It also expands to look at how the environment helps influence the things that we see and the things that we experience and the behaviors that come about because of some of the things that go on with us. And so it gives us a common language. ICF model gives us a common language, but it also opens up the realization that contextual environment influences some of the things that we do. In 2003, there was another major reform to Medicare, and at that time, 2003, Bush signed in the Medicare Prescription Drug Improvement and Modernization Act. And what the important thing for this was it added an optional drug benefit to Medicare. Before that, drugs were paid out of pocket, and in people as they get older, or in people who have a lot of health issues, pharmacological interventions, drugs and medications cost a lot of money. And so even though people were paying their Medicare, their medical coverages were being paid, they were still going into poverty or not able to afford the medications to keep them healthy. So with this realization, government and Bush signed into legislation the Medicare Part D, which gives people who are older or people who cannot afford it pharmacological relief. It gives them funding to help provide for the medications that they need. The interesting thing is that it's not federally funded. Medicare Part D is provided by private insurers, and so the government contracts with private insurers to provide the drug and medication component of Medicare. And this leads to more current topics. So within the past decade, 2010, President Obama, one of his major legislative platforms of his legislation was to get across medical care for the masses. And so what he signed into effect and he got through legislation was the Patient Protection and Affordable Care Act, also known as Obamacare. And it was meant to provide coverage for people, but it was also meant to reduce the cost of healthcare. The interesting thing, it had three main components. And so as we start to study not only Medicare, but also the Affordable Care Act and the Obamacare, we have to realize that these are things that are still currently on public consciousness. It's also currently within current legislative platforms. It influences healthcare policy and affects our professions these days. So to understand the components of the Affordable Care Act, the Affordable Care Act really had three main components. One was to make sure that everyone could be insured. No one would be excluded from pre-existing conditions. So that was important, because prior to that, people who had life-threatening injuries or illnesses, a lot of times insurance companies would not provide them with insurance because it would cost too much money. And so what ended up happening is these people would go uninsured, and they would either have poor quality of medical care, no medical care, or they would go to federally funded medical care, which would be a burden on the federal government. So one of the main components of Obamacare was to make sure that everyone could get insured. The second component of Obamacare was to make sure everyone, regardless of your age or regardless of your health status, they were required to take out insurance. And the insurance, they were required to have insurance, I believe it was 9 months out of the year. This requirement for every person to have insurance was known as the individual mandate. And this is important because it's a very touchy political time bomb. It's used as major platforms for candidates as they look to be elected. This individual mandate is an important concept to know. Why do people have the individual mandate? Because in order to keep healthcare policies down, it's important to have more people paying into the system. Because remember, component one was to allow people who had a lot of trauma or needed a lot of medical care into the system. Well, how are we going to pay for this? Well, we can only pay for it if the healthy people require to be in the system as well. Just having the healthy people offset the needs of the people who are unhealthy. And so that's how it was proposed that we keep healthcare costs down. So the individual mandate was an important concept of the Obamacare and Affordable Care Act. It's only through the individual mandate that you can keep healthcare down. Federal funding subsidies would provide to help provide everyone affordable insurance. So the third main component was this concept that when people, in addition to the individual mandate to help offset the costs for medical care, the federal government will provide subsidies to help offset these costs as well. So those are the three main components. One, everyone can get insurance. Two, all people had to pay into the pool. And three, the federal government would help subsidize and keep healthcare costs down. That was the essence of Obamacare. So the question that we have for you is that it's been recent that Obamacare took place, and it's still its effects are still being seen through our professions. So I want you to sit and think for a second. How did Obamacare affect your area of specialty, whether it be PT, ATC, MD, OT, DC, or other? Sit and think about how Obamacare affected it, because these are points of discussion we're going to be talking about in a couple days in our Zoom in times together. The one thing that's the most current change in the medical history or medical reform is we're going to talk about now. It's this concept in 2017 that legislation passed, and it was called the Tax Cuts and Jobs Act. Now, this might have gone under the radar for some of you, but it has important consequences towards our medical health care provision these days. So in 2017, Congress repealed the individual mandate tax as part of this Tax Cuts and Jobs Act. So my question for you that we'll be discussing is, what do you think the effect of this Tax Cuts and Job Act is going to be on medical care and your particular subspecialty? Think about that, and that'll be a point of discussion that comes up in our talks in the next couple of days. Whether it be next couple years, or the next 4 years, or whenever, we always have an election around the corner. And regardless if it's this year, next year, or the following year, healthcare is always a key platform in politics. And it's the politicians who drive our healthcare reforms and legislations that affect us and our professions. So understanding healthcare is a key issue in politics, but it's also a key issue for you as leaders in your fields. So my question for you as a leader is, what are the current and new proposals for healthcare reform? What do they involve and what do they change? And how will they impact your area of specialization? So the last one we talked about was the tax cut in 2017. Elections are around the corner. What are the key healthcare reform proposals that different candidates are suggesting? Want to be able to discuss some of those in our Zoom-in meetings in the next couple days. So think about that. So that ends this module on domestic policies. I talked a lot about the historical policies that have gone through healthcare over the course of the last 100 years or so. That sets the foundation for our discussions that we'll be having this week and the following week on the different healthcare reform bills and legislation that is currently in the news. We want to talk about it as a group and see if we can figure out how these different reforms potentially impact us as a profession and you specifically in your profession. So think about these. We'll discuss it over the next couple weeks, okay? Take care. We'll see you in a couple days.